broadcast in 9 other cities in eastern part of India. And I'd like to take this occasion for thanking all the chairpersons in different locations and the doctors who are also joining at different locations. To start with, we will have a lecture for about 20 minutes, and there will be 10 minutes for discussions. And I would request Dr. Manisha who is a consultant at Peerless Hospital, to take the role of a conductor of this meeting. Dr. Manisha.
A very good evening and a warm welcome to everyone over here. We start our program today with a very interesting topic on incretins. These are a group of gut-derived hormones that play a predominant role in metabolism and energy homeostasis. Now, I'll request Professor Sujoy Ghosh of SSKM to come up on stage, please, sir, to deliver his talk. And I will also request Dr. Kollan Gangopadhyay of Peerless Hospital and CMRI to chair the session, please.
So I'll start with an unusual announcement. Is there anybody in this hall who doesn't know Dr. Sujoy Ghosh? No. So I think there you go. So we'll start. So incretin based, it is now become the backbone of future trials, because just about a couple or 2 or 3 years ago, we thought that the new molecules for diabetes has ended. We won't be getting any new molecules. But the obesity spectrum, the drugs in the obesity field have increased exponentially, and we have got multiple drugs, all of them almost targeting the incretin-based therapy. So over to you, Sujoy, for incretin-based therapy in metabolic disorders, or incretins in metabolic disorders.
Thank you so much, Kollanda. Big thank you to the organizers, particularly Professor Konar, for having given me this wonderful opportunity to interact with this audience. I actually have a very, very difficult task to talk about incretins in metabolic disease in 20 minutes, something which is actually going to be the group of molecules in the next 1 or 2 decades. And before I jump into talking about incretins, a little bit about obesity. Because if you look at non-communicable diseases in India right now, 2/3 of all deaths happen because of non-communicable disease. Even when we were all talking about COVID and COVID deaths, more than 50% of the death during the COVID period happened because of non-communicable disease. And unfortunately, when I met the first health secretary after joining my service, I had actually gone and spoken to him about non-communicable disease and the importance of it in India and West Bengal per se. উনি আমাকে বলেছিলেন না, হার্ট অ্যাটাক আর ডায়াবেটিসে মৃত্যু হলে খবর হয় না। সো ইনফেকশাস ডিজিজ ইজ খবর, শিশু মৃত্যু হয়েছে খবর। So we have accepted as if having a heart attack and death, a stroke and a death as normal. But if we really want to change the landscape of health of our country, we have to concentrate on non-communicable disease. And the mother of all non-communicable disease is obesity. So if you're talking about hypertension, diabetes, dyslipidemia, fatty liver disease, all of that begins with obesity. Now, this is what the international world talked about defining obesity. You know, we have separate India-specific cutoffs, BMI less than 23 being normal and above 25 being obese. Those of you who have read the Lancet Commission a couple of months ago will agree that this definition of whatever we are using in terms of BMI is rubbish. What matters is your body composition and the amount of body fat that you have. We have recently conducted a study on 3 medical colleges, NRS Medical College, Kolkata Medical College, and PG Hospital, and looked at girls from first year. We are following them up for 6 years. And the average percentage body fat of MBBS student girls is 43%. So anything more than 30% in girls and 25% in boys is considered obesity. So we will have to think of redefining obesity in a different manner. And if you're looking at the proportion of people who are obese in the MBBS girls, more than 90% are obese. So that is going to drive your future NCTs. So there is actually a list of 267 diseases that obesity causes. This is just some of them that I have highlighted here. And it has got multiple reasons why this is happening. And a lot is to do with our lifestyle. When we were students in my school in St. James, maybe in a class of 50, we had two people who were fat. Jader amra mota boltam. We did not know what body shaming meant then. Now my daughter doesn't call anybody fat in her school because everybody is fat. And there is so many reasons. I'm not going into that. And you can see there have been so many guidelines that have been published in recent time, essentially telling us we don't know how to manage obesity. And now at least the international world is recognizing obesity as a disease because that has implications in terms of insurance and things like that. Recently, I was in Delhi to write the childhood NCD guideline for India, in which we have included obesity as a disease, at least in children. And in this entire slide deck, I have actually borrowed slides from the Lilly slide deck and a bit from Novo slide deck is because I cannot complete everything. So I thought I would just pick up bits and pieces, and particularly with more emphasis on Lilly, not because Lilly has sponsored this program, they haven't, is because this molecule is already available. We will get the injectable semaglutide maybe in the month of June or early July. So all of us know what is an incretin or incretin-based therapy. So you all are aware of Michael Knock's paper that if you take 100 grams of glucose orally versus you infuse 100 grams of glucose intravenously, the insulin secretion is more when you give it orally. The bioavailability of glucose, both oral and IV, is the same, but the oral glucose does something in the gut which causes release of certain hormones, which we call incretins or intestine-derived hormones, which augment insulin secretion. That's how the name came. And we all thought this has only to do with what happens inside the brain-gut axis and nothing else. But we know now that it has got influence in almost everywhere. So on the left-hand side is what we have always talked about. Whether you talked about the DPP-4 inhibitors or drugs like, say, oral semaglutide, or say like injectable Trulicity or dulaglutide and things like that. The ones on the right are ones that we are now concentrating on, whether it's weight, whether it's blood pressure, whether it's lipid and other things, the ancillary benefits. So we now know that you have certain glycemic benefits and you have certain extra glycemic benefits of this class of molecules. And if you look at this entire spectrum of drugs that we are now talking about working through the incretin pathway, you can have some which are changing the GIP, some which are changing GLP, some which are acting on the glucagon receptor, some which are acting on FGF1 agonism. So you now know some acting on glycentin and also as amylin. So depending on which molecule you are talking about, there's going to be this permutation and combination of incretins. So tirzepatide, for example, works on GLP-1 as well as GIP. Retatrutide is a drug which Lilly is going to bring thereafter. We are doing clinical trials on that, which causes 27% weight loss, is a GIP, GLP, as well as a glucagon receptor agonist. Novo is bringing a molecule called cagrisema, which is a cagrilintide with semaglutide. The cagrilintide will act through the amylin pathway. So if you're looking at the gut and you're looking at all of the gut hormones, you have a permutation of combination of what is going to work where. Honestly, we still don't know in the long run what will be the effect of each of these. And therefore, one of the things that you need to understand is you can't club all of those drugs together as they might be of the same class, but each will have a different kind of an effect. So the one which are going to go for glucagon receptor effect or the FGF21 are more likely to have better results in, say, metabolic liver disease. Whereas when you're talking about glycemic control, maybe the cagrilintide will have a better effect. So we are all talking of this as a one class of drug, but there will be differences between them. So we should not be comparing it. This is not like an SGLT2 inhibitor. Say dapagliflozin din, empagliflozin din, ঘুরে ফিরে একই effect হবে. This is not going to happen. So what I wanted to highlight, because most of you would have used GLP-1s, whether it is Victoza or liraglutide or say Trulicity. So you are aware of all of these things, that it works at the brain, at the level of the gut, at the stomach, as well as the pancreas, with various effects. And one of the things that you've looked at is it reduces glucagon. Now the GIP reduces food intake, but you will see there's one more thing. It talks about increases glucagon. So on one hand, you are saying this drug causes decrease in glucagon, that causes increase in glucagon, then the blood sugar should have gone up. This is a paradoxical effect of GIP, that only when the glucose drops, the glucagon is increased secretion. So there is preservation of glucagon if you are adding the GIP. That's a paradox. And the other thing that you've got to remember is the GIP has certain effects on the adipocytes, which the GLP-1 does not have. And it increases the adipocyte lipolysis and intake into the fat cell. So unlike all of the other ones where you're just suppressing or decreasing intake alone without doing anything in terms of the metabolism of the fat cell, the GIP has got additional effect. I'm not going to complicate things. So Mounjaro is the brand name, and it works both on the GIP as well as the GLP-1. And how does it work? Predominantly by reducing energy intake and appetite, increase feeling of satiety and fullness, decrease feeling of hunger. Now, obviously, this will come at a cost of nausea and vomiting. I'll talk about that as well. So you can have glycemic benefits, weight reduction, lipid metabolism benefit, and cardiorenal benefits. I'll quickly go through some of the data or the studies that are there. So in terms of the glycemic control, the predominant benefits, the beta cell function, improving insulin sensitivity, and the glucagon control. So if you look at all of these classes of drugs have been used in two sets of disorders. One where you're trying to treat hyperglycemia or diabetes, and the other for obesity. These are the two primary indications of all of these drugs. Now, one of the things that you've got to remember, if you have diabetes, you will have less weight loss compared to if you're treating obesity in an individual where there is no diabetes. So that's, therefore, when you're predicting the amount of weight loss, the first biggest predictor will be, do you have diabetes or do you not have diabetes? If you have diabetes, you will still have weight loss, but the quantum of weight loss is going to be less compared to those without diabetes. And for each of these subclasses or indications, that is the drug in the study being looked at predominantly for diabetes management, you have the SURPASS group of studies. If it is obesity management, you have the SURMOUNT group of studies. So like I've just shown this as a summary slide. So you see the first one where it is being used as against placebo. Then here against semaglutide injectable 1 milligram. Remember, semaglutide's injectable dose is right now is 2.4 milligram. They are now doing trials with 7.2 milligrams. So it's as a comparator with that. Then with insulin degludec, with glargine, and with placebo with insulin glargine versus metformin. And all of the trials show that there is significant reduction in HbA1c. In the past, when did we see a drug truly having an HbA1c reduction of more than 2? Everything else that we talk about apart from insulin, we say what? 0.8% HbA1c reduction. So you understand this group has much more robust HbA1c reduction. And the CLAMP study shows that the first phase as well as the second phase of insulin secretion is improved with SGLT, with incretin-based therapy, whether it is semaglutide or whether it is tirzepatide. And the glucagon that I was talking about, the GIP action actually makes sure that the glucagon response is intact, which is good in a way. That means if a patient has hypoglycemia due to any reason, the glucagon will help the patient to recover from the hypoglycemia. Weight reduction. So As you can see, there is a sustained weight loss with whatever dose of tirzepatide that you're talking about, whether 5, 10, and 15. And you can see up to 72 weeks, if you look at, you have a weight loss somewhere close to 15 to 20% in individuals. And you want the patient to lose fat and not muscles. Now, in spite of what is going on, we still don't know the 100% truth. There will be some muscle loss along with the fat loss. Now, one of the things that the pharma industry is trying to tout is that the muscle also has some amount of fat. So when you're trying to estimate muscle versus fat, it could be the muscle fat which is lost, but I think that's not true. We will have to educate our patients to undergo resistance exercise and weight training so that muscle loss is minimized. And you can see the body composition, that is proportion between fat mass and muscle mass, definitely improves. And there is definitely decreased craving. Patient এসে বলেছে আর বিরিয়ানি খেতে ভালো লাগছে না, which can be actually a distress to the patient. That also you have to remember. Now, lipid metabolism also, I just wanted to show that there is improvement in the lipid parameters, whether you're using whatever dose of semaglutide or tirzepatide, and the cardiorenal benefits. As you can see, the pulse rate increases, the blood pressure decreases, and if you're looking at the EGFR as well, because that's the renal part of things, there is definite decline in the rate of decline of EGFR. And this is the SURPASS trial, which shows that there is no increase in the, remember there is a dedicated cardiovascular outcome trial going on for tirzepatide. For semaglutide, you already have the SELECT study, which shows that there is reduction in the 3-point MACE. That means it is cardioprotective. So key takeaways from that bit, I've already told you this is where the predominant areas that this molecule acts. So moving on to the SURMOUNT program now. That was the SURPASS for diabetes. The SURMOUNT is for obesity management. So these are the 4 major studies that have been published for SURMOUNT. One is against placebo. The second one in patients with diabetes. The second group. This group had diabetes. This group did not have diabetes, but did have some people with pre-diabetes, which actually improved. The third group again is versus placebo after an intensive lifestyle. And the SURMOUNT 4 is to make sure that what about weight maintenance? This is about loss. What about weight maintenance study? So if you look at around week 4 itself, there is a weight loss that starts, and that is sustained for over 1.5 years. And average weight loss is again about close to 20 to 25%. And the change in body weight, you can, if you look at significant weight reduction with Mounjaro, which continues and is to some extent dose dependent. Powerful reduction in body weight with Mounjaro. 4 out of 10 patients, that means 40% of the patients will lose 25% of their weight, something very close to bariatric or metabolic surgery, when we said metabolic surgery can lead to weight loss up to about 30%. And if you're looking at DEXA images to look at body fat, there is predominantly fat loss rather than lean mass or muscle mass loss. And again, the waist circumference, you can see almost 1% of weight loss will lead to 1 centimeter of waist circumference reduction. So that's an indirect way. So if you want to lose 20 centimeters, you will have to lose about 20% of your body weight. So if I summarize in terms of the blood pressure, the triglyceride, the LDL, they improve. And what I told you in terms of the SURMOUNT 1, the pre-diabetes group, there was reversion of almost 95% of those pre-diabetes patients to the range of normoglycemia. So I thought I would just again, because sir had asked me to speak, talk about MASLD. Now, there are 2 studies. For semaglutide, the ESSENCE trial already has been published, and this is interim analysis of the tirzepatide molecule. And if you look at, this is the Synergy-NASH study, phase 2, showed that up to 73% of participants treated with tirzepatide achieved resolution of MASH without worsening of fibrosis. This is the study design. I'll skip that. And a significant proportion will have more than 1 stage decrease in fibrosis with no worsening of MASH. Essentially, we all want that the fibrosis should reverse. That is the ideal thing that we are looking at. Now, if you're looking at some of the recent data, we now know in F2 and F3, you will have around 30 to 40% in which the fibrosis will reverse. A trial has been published yesterday in New England Journal of Medicine with another molecule in F4, which showed that it did not work. So maybe once it's F4, you will not be able to reverse. It did not increase the progression, but it halted it. So this is some of the baseline and clinical characteristics. I'll stop with that. Now, I can actually go on with all of these topics. When you're looking at the incretin-based therapy, of each of the molecules, you have most of the data for type 2 diabetes, whether it is survodutide, whether it's tirzepatide, whether it's semaglutide, whether it is cagri-sema, whether it is retatrutide. It is established. When you're talking about obesity, some of them have established trials, some have ongoing studies. With ASCVD, you have the SOUL study and you have the SELECT study, which is already published, which shows that it improves cardiovascular disease. Now, one of the things, if you look at the ADA-EASD guideline, it talks about if you have ASCVD, consider using a GLP-1 or an incretin-based therapy with proven efficacy or SGLT2 inhibitor. I think this has to change. It cannot be A or B. Why? Because the incretin-based therapy will actually change atherosclerotic cardiovascular disease. And if you're looking at heart failure-related events, that will change with SGLT2 inhibitors. So when you're talking about GLP, either ASCVD or heart failure or renal disease, we are talking about A or B. I am certain in the near future it is going to be A plus B and not A or B. You don't doubt when you are treating, say, heart failure with the 4 pillars of management. Do you now any longer talk about A, then followed by B, then followed by C, then followed by D? You are trying to give all of them together to give the maximum benefit. Now, in terms of heart failure, preserved ejection fraction heart failure, if we are looking at, this class of drugs is here to stay. Because it has got several mechanisms of action through which particularly preserved ejection failure, heart failure, the GLP-1 class of drugs are going to stay. MSLD I already talked about. In terms of the renal benefit, we already have the FLOW trial and the SELECT trial, which shows that it improves renal outcome. Now, if you're looking at the quantum of benefit of renal outcome, there are several meta-analyses which show that SGLT2 inhibitor plus the incretin group of drugs both have renal benefits, but SGLT2 probably have a greater quantum of benefit. I'll finish within 2 minutes. And that's the renal bit. Obstructive sleep apnea, we have several abstracts which are already published, which shows improvement in obstructive sleep apnea. In terms of the safety, very quickly, the commonest side effects is that of all of the GI side effects that we already knew about the GLP-1 inhibitors. Does the dual inhibitor have greater side effects as compared to the single GLP-1? Answer probably is no. And no risk extra signals of pancreatitis, because that was something that we had thought of our pancreatic malignancy. And discontinuation rates. Discontinuation rates is about 6 to 7%. Probably in India, it's going to be even more because of the GI side effects from our clinical trials done in India. And every time you up titrate, you have it. So one of the things that I've told patients, apart from trying prokinetics, change in meal, is taking longer time to up titrate rather than what is recommended, and sometimes increasing the duration between injections so that the patient can adapt to the problem. So incidence of nausea, you can see, vomiting and diarrhea similarly. Personalized dosing, because I started off with Mounjaro because this is what is available in vial, not yet in pen. So you start with 2.5 milligrams subcutaneous once weekly. After 4 weeks, you escalate to 5 milligram. Thereafter, every 4 weeks, up titrate by 2.5 milligram to a maximum of 5, 10, or 15 milligram. I think I should stop here for questions because I think it's a very, very detailed talk. Thank you very much.
Okay, thank you, Dr. Ghosh. So, any questions? You've got mics interspersed in the hall. Please raise your hand. Okay, please come to the mic in front of you.
will concomitant use of this Monjuro and insulin neutralize the weight reduction benefit of the molecule?
Right. So I think I was trying to show two of the studies wherein the drug has been used in combination with insulin. So the first thing is, whenever you are using this drug in patients with diabetes, that will offset some of the weight loss that we talked about. When you're talking about adding it with something like insulin, the weight loss will probably be slightly lesser. That's expected.
I think this trial which you showed, there was on top of insulin. So
So-
insulin নেওয়া সত্ত্বেও যতটা weight হয়েছে,
হ্যাঁ, কিন্তু
after
আমার
giving the
আমার
digestive-
ধারণা যে কটা আমরা ট্রায়ালে ইউজ করেছি না, ওই 20% 22% আর হয় না তাদের।
Okay,
You
next question.
mentioned that tirzepatide will reverse pre-diabetes.
That's the data.
Now, if we stop tirzepatide, what happens?
Right. That's the Surmount 4 study. So if what they did was, first you gave a placebo versus a treatment arm, right? And you followed them up. যেটা প্ল্যাসিবো গ্রুপ ছিল তারা যেমন ছিল তারা তেমন থেকে গেল। এবার যারা এই ওষুধটা পাচ্ছিল এতদিন, একটা গ্রুপে আপনি বন্ধ করে দিলেন আর একটা গ্রুপে আপনি কন্টিনিউ করলেন। So if you stop the drug, there is a tendency that the weight goes back upwards. But if you continue, the weight loss is further sustained or at least maintained.
What about the pre-diabetes?
There is no data for the Surmount group to show যে আমাদের যাদের রিভার্স হয়ে গেছিল তাদের তারপর বন্ধ করে দেওয়ার পর কি হলো। আচ্ছা, এই রিভার্সাল শব্দটা বোধহয় ঠিক নয়, perhaps we should use the word remission, partial remission for some time.
Okay, Devashish.
So you have very nice talk.
Thank you.
Very, very potent drugs. And obviously it's doing miracles with all the factors. But do you have any long-term concerns about the side effects?
I think
that-
we need long-term data.
Yeah, so that's
We don't know actually.
Yeah.
All of a sudden something might come up
Yeah, so I think
that we don't know.
that's the thing I always wonder, because these are very good drugs. 5 years, 10 years down the line,
I don't
think
know.
we'll have-
I don't know. It's anybody's guess.
So at this point
At
of
this
time,
point, we have data for about 4 years.
So at this point of time, the GLP-1 based drugs have been there for now, or more than a
Yes.
decade. So
এই
we haven't
dose-এ
come
নয়
across
কিন্তু।
any new unwanted adverse effects. But this GLP GIP is new. So that's only 2 years data. So we need more data. So the pancreatitis issue, I did a meta-analysis which there actually the DPP4 inhibitors seem to cause more pancreatitis than the GLP-1 receptor agonists, which was a bit of a surprise to me. The issue of retinopathy is there.
NION.
All these trials, they have excluded patients with unstable retinopathy or quite advanced retinopathy. But those who haven't got retinopathy, have got mild retinopathy, there hasn't been any progress in these trials so far. So these two alarm signals, if there is a history of pancreatitis, I may avoid. And if there is unstable retinopathy or progressive, quite bad retinopathy, then I might avoid.
And if there's a history of medullary thyroid
Thyroid
cancer.
cancer, yes.
Good evening, Dr. Ghosh.
Okay, is there any other questions?
Good evening, Dr. Sujay Ghosh. This
If
is
not,
Dr.
thank you very much, Dr.
Thank you.
Sujay Ghosh. I hand it back over to Dr. Manisha.
Just a minute.
So coming to our next topic, antimicrobial resistance, one of the top global public health threats. It continues to challenge healthcare systems worldwide, complicating our treatment strategies and driving an urgent need for novel antibiotics. So what's new in antibiotics and antifungals? May I request Dr. Subhash Todi of Manipal Hospitals and Dr. A. Kisharkar of Peerless Hospital, please, sir.
Yes. So Dr. Todi doesn't require any introduction, I presume, and everybody knows him. He's a very good orator, and we are all here to hear something new from him regarding our antibiotic armamentarium and antifungal armamentarium. Dr. Todi, please.
Thank you, Ajay. My talk will be mainly based on hospital-based antibiotics. Not antibiotics used in the outpatient department. And most of them will be used in sick patient. And the reason that, I am here and this topic is here is because of this. I'm sure you have all faced this kind of multi-drug resistant gram-negative infection. It is there everywhere in all nursing homes and hospital. E. coli, Klebsiella resistant to carbapenem. Acinetobacter, Pseudomonas, sometimes resistant to most of the antibiotics. So what do we have for them? Most of the antibiotics that I'm going to talk about are presently available in India and or will soon be available in India. They are not in a trial phase anymore. So I have to cover gram-negative, positive, and fungus. So I will go quick. So going on gram-negative, since we are in the era of war, you have to, in order to win a war, you have to know your enemy. And this is the enemy. And the most important is this gram-negative bacteria have a cell wall outside and
Subhash,
a cell.
Slides are not moving.
Not moving. So do I have to press this? Okay. So this is the carbapenem resistant, Klebsiella pneumoniae, the Pseudomonas, Acinetobacter. And I have to cover gram negatives and gram positives and fungus. So this is the enemy that we have to deal with. You see, gram negative is very peculiar. It has got a cell membrane and a cell wall, outside the cell wall and inside cell membrane. And there is a periplasmic space in between this, which contains beta-lactamases, and that will kill almost all the antibiotics. So that is where the problem lies of the current antibiotic. They are killed by the beta-lactamases in this periplasmic space. And this is the ICMR data on the antibiotic resistance to carbapenem. I'm sure you will find in your ICUs and even in the ward in the hospital, many of the Klebsiellas, Acinetobacter is almost universally now resistant to carbapenem. So now what to do about this? Now, there are two kind of ways to look at it. One is the beta-lactamases types. There are 4 types of beta-lactamase. One is I will call ESBLs, that is type A. Type B is New Delhi metallo-beta-lactamase. Type C is AMC and type D is OXA. Why are these important to know? That different antibiotics will work against different beta-lactamases. But we don't have this report of whether the patient has AMC or NDM or OXA or ESBL. We have reports like this on the right side, the phenotype. And it is very easy to know the genotype by looking at the phenotype. Let me tell you, go through this because this is important. If you get an antibiogram where the bacteria is resistant to cephalosporin, resistant to ceftriaxone, resistant to ceftazidime, but sensitive to carbapenem and piperacillin tazobactam, this is ESBL or class A. If you have a bacteria which is resistant to cephalosporin, resistant to carbapenem, and sensitive to ceftazidime avibactam, which is available very freely, so this is OXA or class T. If it is resistant to cephalosporin, carbapenem, and ceftazidime, then it is NDM. AMP-C is not that common, but this is a very peculiar beta-lactamase where cefepime is sensitive. All the other cephalosporin are resistant. So if you look at your antibiogram, you know which kind of a genotype your bacteria has. And then we can discuss which antibiotic might work against which. So in a carbapenem resistant bacteria, 1/3 in our country is OXA, 1/3 is NDM, and 1/3 is combination. Many of these bacteria have combination of these resistant mechanism. So let us start with ESBL. You have a patient which has a blood culture of E. coli, has pyelonephritis. It is resistant to cephalosporin, but sensitive to piptase and carbapenem. We used to give piptase a lot, and still people do give piptase if the antibiogram says it is sensitive. That is what is the stewardship tells us. And meropenem. Yes, the sicker the patient is, we tend to give meropenem, but this patient is hemodynamically stable. Then what to do? So it was 50-50. Some doctors used to give piptase, some used to give carbapenem. Nobody knew which was better. Till this study was done, a very pivotal study called Merino study. They compared piptase with carbapenem in exactly the sort of patient I spoke about. And what they found was carbapenem was much, much better than piptase. It saves more life. Both are sensitive. You see, you get an antibiogram, both are sensitive. But still carbapenem is better than piptase because the sensitivity and resistance that we get from our microbiology lab doesn't look at all the resistance mechanism. And what they found was most of these ESBLs also had this enzyme called OXA1, which is not reported. The lab will report it as piptase sensitive, but clinically there is going to be failure if we give piptase. So a lot of bacteria had this OXA1, which is not picked up in the routine bacterial antibiogram. So that is where the problem. So people started giving, now we give carbapenems. If there is an ESBL, carbapenem is the drug of choice. So does everybody needs carbapenem for ESBL? That becomes a big problem. And that's why there is huge rise of carbapenem resistant Klebsiella all over the world and more so in our country. Then what to do? So this is a new drug which has recently been launched in India, cefepime enmetazobactam. This is, if you look at it, it works against ESBL, it works against AMP-C, it works against OXA, doesn't work against NDM. It's a good drug, and this was first approved cefepime beta-lactamase combination for drug-resistant Enterobacteriaceae. And there have been studies on this in JAMA, which have compared it with piptase, and it is much, much better than piperacillin tazobactam. The only problem is we still do not have a study to compare this drug with meropenem, with carbapenem. So if you have an ESBL, this is better than piptase, but we don't know whether it is equal to carbapenem or not. This will soon come. But at the present moment, this will be a good drug. If you have an ESBL, if you have a pyelonephritis, if you don't want to give carbapenem, you can use this drug. It's a very good drug against ESBL. And there have been studies looking at overall success from piperacillin tazobactam. And it has been FDA approved in many ESBL infections. So this is one of the newer drugs, cefepime enmetazobactam. So remember that. You have an antibiogram, cephalosporin resistant, piptase sensitive, carba sensitive. They might not give cefepime enmetazobactam because Many of the labs don't test it, but you can use it. Another patient, Klebsiella, it is resistant to carbapenem. It is resistant to piptase. So you see colistin, though we have, colistin should not be used. Polymyxins are not good drugs. Since we didn't had any choice, we had to use it. But even the sensitivity has been withdrawn from colistin. It's no more sensitive because if you give S, a lot of people will use it. So universally, internationally, they have withdrawn sensitivity from colistin or polymyxin. It should not be used. But it is sensitive to ceftazidime. So ceftazidime avibactam, if you have a carba-resistant infection, which is sensitive to ceftazidime, that means it is OXA. And this is a very good drug against OXA48. If you look at down here, it's a very good drug against OXA48. So that is the second drug. So if you have cephalosporin resistant, carbapenem resistant, you have a bad infection, and you must ask your lab to do ceftazidime sensitivity. If it is sensitive, you don't need any genotype, it's OXA. So you can give it. Now you have ceftazidime resistant, cephalosporin resistant, carba resistant, even ceftazidime resistant. Then what you do? This is NDM, New Delhi metallo-beta-lactamase, which is resistant even to ceftazidime. There you do this test. You must ask the lab to do this test where they put a disc of aztreonam and a disc of ceftazidime. If these two are combined together, then it works. The bacteria gets killed. This is called synergy test. It is resistant to ceftazidime, but if it is combined with aztreonam, this will work. So the synergy test is positive. If it is positive, then you give these two drugs together, ceftazidime, avibactam. So a lot of doctors now in India are using it because we have a lot of NDM, carba resistant and ceftazidime resistant. The reason is aztreonam acts against NDM, but aztreonam is hydrolyzed by ESBL. So combining an avibactam to this works. So this new drug is now going to come. The ceftazidime is going to work against NDM. And there have been quite a few studies from India which have shown that ceftazidime aztreonam is better than colistin because we didn't have any other antibiotic apart from polymyxin or colistin for this group of bacteria. So there is a problem of combining ceftazidime with aztreonam. They both have to be given at the same time. You know, in two arms, ceftazidime going in one arm and aztreonam going in another arm at the same time. The bacteria has to see both at the same time, which is a bit difficult to do most of the time. That's why this new antibiotic, it is going to come very soon. Aztreonam avibactam will be launched this year. And so we don't need ceftazidime. Thus, just we need the avibactam part of this, which will hydrolyze the ESBL so that aztreonam can work. So if you get this molecule, aztreonam avibactam, you have a bacteria which is resistant to cephalosporin, resistant to carbapenem, have a ceftazidime resistant, but synergy is positive. You have done the synergy test, it is positive. This will be a very good drug for that. Now you have an NDM, which is if you have a synergy negative, you have a bacteria which is resistant to cephalosporin, resistant to carbapenem, resistant to ceftazidime, and you have done a synergy test, it's not working. So giving a ceftazidime with aztreonam and giving aztreonam avibactam is not going to work. Then what you do? There are two drugs. This drug is an Indian, this Indian discovery is going to come very soon in India. Cefepime ziribactam. It's a very good drug for synergy negative New Delhi metallo-beta-lactamase. There have been studies on this. and this is another drug called cefepime tenimorbactam. These are the two drugs which we should be coming anytime in the market. This can be given for a carba-resistant gram-negative infection. So I think you have to watch this space, and these drugs will come very soon in the market. It will work against everything except Acinetobacter. Doesn't work against Acinetobacter. Then what to do? You have a patient which is resistant to everything, including ceftazidime, and synergy is negative. And they are not responding to this newer BLBLI, like cefepime, zidibactam is not responding. Then what you do? This is another aminoglycoside, which is again going to launch probably in a couple of months, plazomicin. Now, what is plazomicin? Plazomicin is a newer aminoglycoside which will work against this, what is called penicillin binding protein 3 mutation. This is a very peculiar mutation in E. coli. Lot of our E. coli in India, which is resistant to cephalosporin, resistant to carbapenem, they are synergy negative. That means only the PBP3 mutation, so the combination of ceftazidime, aztreonam is not going to work in this patient. And this is a very good drug for complicated UTI. This is FDA approved. So this is going to come very soon. So if you have almost a pan drug resistant infection and you have synergy negative, you can use this. Now, what about Acinetobacter? Acinetobacter, these are the antibiotics which we have been using till now. What is sulbactam, mino, TG, phospho, colistin. But these are not very strong drug against Acinetobacter. We have so many patients dying of pneumonias due to Acinetobacter. What are the best drugs? This is one of the best drugs for Acinetobacter, sulbactam durlobactam. This is a very novel antibiotic. This is dual beta lactamase. Now, how does it work? You see, sulbactam is the backbone for Acinetobacter therapy. It has to be there, sulbactam. But the sulbactam is killed by the beta lactamase. So this durlobactam is another beta lactamase, which will allow the sulbactam to enter the Acinetobacter. Till now, this is the most potent antibiotic against Acinetobacter. This is available as Xacduro. The second is the eravacycline. Again, a new tetracycline, which is a novel mechanism of action. It will work against Acinetobacter. This is the wonder antibiotic. It is going to come very soon. Cefiderocol. This is available in the gray market in India. I've given it to a few patients last few months. Fitroza. Fe is for iron and Troza is for Trojan horse. As you can see, this even the symbol of Trojan horse is there. Now, why is that? We don't give iron in septic patients. We don't give intravenous iron. The reason is bacteria loves iron. Whenever you give IV iron, the bacteria will increase. So what they did was very clever. They had an iron molecule tied to this cephalosporin, and they used the iron channel to get into the bacteria. And once they got into the bacteria, they dissociate from the iron channel and then kills the bacteria. So that's the Trojan horse part of it and the iron, Fe part of it. This is called Siderophore antibiotic. And if you see, it is cefiderocol is green all throughout. It kills all the bacteria, including Acinetobacter. But if not used judiciously, all the bacteria are much more smarter. They will get resistant to cefiderocol. But till now, cefiderocol is going to be a very, very potent antibiotic for pan-drug resistant infection. So this is how my scheme of antibiotic decision tree would be. Gram negative, if you have E. coli, Klebsiella, Pseudomonas. If it is ESBL, carbapenem, or nowadays cefepime and metazobactam. If it is oxa, ceftazidime. If it is NDM, you do a synergy test. If synergy positive, you give ceftazidime aztreonam or you give aztreonam avibactam. If it is synergy negative, if it is E. coli, you give plazomicin. For others, you can give cefiderocol, cefepime tenibot, cefepime zidibactam. In Acinetobacter, these are the choices. Polymyxin probably is still there for Acinetobacter because we don't have the other three. So that might be the only place where Acinetobacter is still used. I will skip quickly through the gram positives. You know, MRSA, these are the present drugs that we use for MRSA and MSSA. But there are a lot of problems with these drugs. So there are new drugs in the market called tedizolid. It is available. It is much more friendly than linezolid. Less drug interaction, less myelosuppression, less thrombocytopenia. And, you know, linezolid as a long-term, you know, gram-positive infections of like bones and joints, you have to give weeks after week of linezolid. This is a better drug for that. Ceftaroline, ceftobiprole, these are the 5th generation cephalosporin, which will work against MRSA and MSSA. You see, again, compliance, this is outpatient antibiotic therapy. This is a big deal. You don't want a patient to stay in hospital just for IV antibiotic. So this is once weekly antibiotic for staff. You can give it for, you know, endocarditis, joint infection, bone infection for months together, once weekly. So this is there in the Indian market. So this can be used as well. This is again an Indian formulation, levonorephoxacin, very good drug against streptococcus and staphylococcus. So I think these are, we don't find this in the Western literature because they are not FDA approved, but we have started using this, and a very good drug against MRSA and MSSA. Finally, to finish, antifungal. You know, just like bacteria, the fungus has also become very resistant to many of these antifungal drugs. And why do we need new antifungals? Long course of therapy, mostly they are IV. You don't know whether it is Candida, whether it is Aspergillus, whether it is Mucor. Different antifungals work in different spectra. Many of these ichinocandins, you know, mica fungin, they don't penetrate the CNS, they don't penetrate the eye, they don't penetrate the kidneys. So if fungus is in these viscera, we can't use ichinocandin, and there is increasing resistance. And this Candida auris, we have a lot of Candida auris in our country. This is a very drug-resistant infection. So these are very important. So what are the newer antifungal? The first is rezafungin. Again, you see, you can give it once weekly. As you know, antifungal has to be given 2 to 3 weeks. And so this can be given once weekly. So very new, novel antifungal, which soon be, and these are all FDA approved, soon be available in the market. So this is the Lancet study on that. Second is this ibraxafungerp. This is available for Candida auris. It also works against Aspergillus. So newer antifungals, which works against both Candida and Aspergillus. And lastly, this very broad spectrum antibiotic, antifungal, works against Candida, Aspergillus, Cryptococcus. It goes into eyes and CNS. So look for this space. These newer antifungals, these are all FDA approved, will soon be coming to the Indian market. And I think we welcome move to the armamentarium of our antifungals. So a lot of these BL-BLI combinations are there for Enterobacteriaceae, for Pseudomonas, for Acinetobacter. And as I mentioned, though we mention genotypes, OXA, New Delhi metallo-beta-lactamase, AMC, we don't need this. Just with phenotype, just looking at the antibiogram of the patient, you know where they belong to. And most of these antibiotics are available. So I think we need to use them very judiciously. Thank you.
Thank you, Dr. Todi, for excellent talk. In fact, we all had the impression that our gram-negative pipeline has dried up, and we are at times really feel frustrated that what should we use. Now it seems that we have got new antibiotics who are equally potent or better potent, and that can be used by every one of us when will be available to us. Thank you again. And if there is any short question, one or two, I can ask because we are running little bit of short time. Any questions from the satellite centers?
Was the
ওই তো
excellent
সমুদ্র
talk.
আছে হ্যাঁ বলো
One question to you. You can unmute yourself. The location you can unmute yourself for any Q&A. Sir, was the one question to you. If you said that the phenotype is enough to understand what the type of beta lactamase is, so when do you ask for a genetic testing in your patients?
You see, your phenotype you get after 48 hours, right? But the game is almost over in 2 to 3 days. If somebody is very sick, the first 3 days of antibiotic is going to save that patient. And we get culture results when after 48, 72 hours. So nowadays with this new genotypic tests, rapid diagnostics, you can send sputum, you can send CSF, you immediately know which is it OXA, is it ESBL, is it NDM.
How authentic is your biofire reports?
Very authentic. These are PCR based. It's like testing for COVID. We never ask how authentic is that COVID PCR. If it is COVID PCR.
So if you are sending a patient, very sick patient, for a biofire assay, what would be the sample size which you want to provide to the microbiologist?
You see, first of all, it has to be done immediately as soon as the patient comes, because at that time you don't have any cultures. You want to choose your antibiotic, and your first antibiotic has to be correct. It has been shown that if your first antibiotic is wrong, ultimately the patients do not survive, even if your second or third antibiotic is right, because those first 8 to 12 hours are very important. So if your microbiology is very strong, you send the sputum, they will say it is OXA. They might not tell you the bacteria. Nowadays, there are cheap card tests. It doesn't tell you the bacteria. It will tell you the sputum has OXA 48. Just give them ceftazidime. It will tell you this sputum has just ESBL. We can give them cefepime N-metazobactam. It will tell you this sputum has NDM. Then you have to give one of those ceftazidime, maybe Bactam plus aspirin. So I think it's very, very potent rapid diagnostics, and that is the future. We have to treat it in the first few hours.
Subhash, the one thing still we have to wait for that culture to become positive before going for any test. But
no, culture, that is the blood culture till now. Blood is the only place where you cannot directly test for these genotypes. Though nowadays there are PCR-based technique which said you send us the blood, we'll tell you whether the blood has any kind of resistance mechanism, but these are not validated. In blood, you have to grow the culture, but after growing the culture, you have to wait for another 24 hours for them to do the sensitivity. So as soon as the culture is positive, we do the biofire test. Tell us what is the resistance mechanism in whatever bacteria this culture is growing. I want to know what is the resistance mechanism.
Thank you. And I think we should stop here if there is no questions. Again, big hand to Dr. Todi for his excellent talk.
Thank you.
Our next topic is based on a very common problem we come across in our day-to-day clinical practice, an update of gastroesophageal reflux disease. For this, may I request Dr. Debashish Datta of Fortis Hospital to come up, sir? And I'll request Dr. Shomnath Mukherjee of CMRI to chair this session, please.
I think it's a pleasure always to introduce my senior colleague, Dr. Debashish Datta, who is a very renowned gastroenterologist in the city, who most of you know. He's the director of gastroenterology at Fortis Hospitals. And we have got a very appropriate topic today, update on GERD, which all of us are facing in all capacities every single day. We look forward to hearing something new from him. Thank you.
Thank you. I think it's a very good introduction. I think probably maybe 30–40% of us here have GERD. So it's an update, but so I'm going to go through some basic things also first, and then will tell us my views how to manage it. So all of you know this. GERD is a symptoms or complication resulting from the reflux of gastric contents in the esophagus and beyond into the oral cavity. Sorry, it's not coming. Slides. Konta change. Is this the change? Oh, so yeah, I've just mentioned that. So regarding the incidence, it's almost equal in males and females, and predominantly in males is actually erosive, and non-erosive you also see in females, which we'll discuss a bit later. I'll go through this slide. This is a very, very nice study done all over India. So in India, you can see there is a lot of variance of GERD, from Ladakh about 18% to quite low, surprisingly, in Vellore around 8.2%. But it's more or less around 20–25%. My guess was it was probably more than that. So what is GERD? So there are three types. One is non-erosive, where during an endoscopy, we actually do not see much inflammation. And that's actually the predominant ones. So almost about 60–70%. The erosive esophagitis, where actually we do an endoscopy, we see changes, about 20–30%, and Barrett's esophagus, which is sometimes will need regular monitoring. And if you look at it, the cause of it is it's actually impaired anti-reflux mechanisms. You all know this. There's abnormal LES function, esophageal metabolic disorder, delayed gastric emptying, and obesity. That's one of the main causes these days for increased incidence. And that's the reason why you are getting more incidence of GERD. So what are the symptoms? You all know this. Mainly the esophageal ones. Patients will present with heartburn and ectosanal burning. In severe GERD, people can have dysphagia. This is one of the worrying symptoms, which I'll come to. And in troublesome symptoms, some will also have simple things like dyspepsia, bloating, and discomfort in the upper abdomen. But there are extra esophageal manifestations. We often get referred with patients who are having recurrent cough, nausea, laryngitis. They are probably having silent GERD and will need investigation. And these are the gradings which we do. So it's a Los Angeles classification. It's basically grade A to D. A is sort of minor. D is where there is mucosal break of more than 70%. So it actually varies from A to D. And that's the classification you will see in our endoscopy reports when we do this. So A is quite simple, but D, you are leading into areas where patients may run into long-term trouble. So what are the diagnostic testing? I think all of you do this. Just give a trial of PPI, and there's nothing wrong in that. But it does not rule out GERD. So if the patients are having persistent symptoms, you might want to do more tests. Barium swallow, yes, we do that, but again, not very common. Mainly, many cases because of dysphagia, we are doing it. Endoscopy is almost a gold standard, and it must be done in patients with alarm symptoms, like patients with dysphagia, vomiting, or weight loss, hematemesis. Esophageal biopsies are sometimes done, especially in cases of Barrett's. Manometry is nowadays done more often, especially in non-erosive esophagitis, where you will consider whether the patient needs surgery or not. Same with ambulatory reflux, pH monitoring. So long-standing GERD, particularly more than age of 50 years, the worry is Barrett's esophagus. So this is a precancerous condition, which you need to take it seriously, where what happens is the columnar cells sort of replace the healthy esophageal cells, and they are precancerous things. So these patients will often need regular monitoring, and they often need long-term acid suppressant medications, which I'm going to come a bit later. And what are the primary goals? Again, you know this. The goal is rapid and sustained resolution of symptoms, crucially healing of esophageal mucosal damage. So I think unless you get the healing, you're actually not getting a cure. And prevention of, and there comes the problem to decide how long the patients will need the drugs to control the symptoms. Now coming to the main core of the topic. So the management of GERD. This is a very important factor which we often forget to tell the patient. That lifestyle management is one of the main things by which you can prevent long-term medication. And as Sujay was mentioning before, obesity has become a very important risk factor, and weight loss clearly improves symptoms of GERD. Medical therapy is often indicated, and you all know that just with lifestyle it doesn't work. Medical treatment is necessary, and you all know this. We have tried H2 blockers, PPI therapy, and prokinetic agent. I'm going to talk about the newer drug PCAB a bit later. So this is what we follow. So if someone comes with the typical GERD symptoms, no alarm symptoms, you give a course of PPI therapy. If there are alarm symptoms, you will go for endoscopy. Alarm symptoms, as I mentioned, is dysphagia, vomiting, excessive nausea, and weight loss, you will go for that. If the symptoms are persisting, often we increase the dose of PPI to double the dose. If it gets better, great. You do maintenance treatment and try and reduce the treatment if you can. If it's not getting better, then the question of more investigations like endoscopy, manometry, or pH monitoring comes in. If there is more acid reflux, you can consider sort of anti-reflux surgery. Or if it's negative, then you may think about functional dyspepsia. I'm coming to the next slide with that. I'm not going to go through this. These are all the drugs you use, the PPIs, and varied doses from once to twice daily. Now, this is very briefly a clinical update from the AGA. What they mentioned is the patient with Barrett's should take long-term PPI. I think we all do that. Asymptomatic patient with Barrett's also should consider long-term PPI. Now, the problems which we are facing, I think this is the main thing which all of you face. What are the limitations? The first limitation is the relapse of symptoms. So you have given the medication, and often the patients have recurrent symptoms. So relapse is shown to occur within 6 months of initiating PPI therapy in around 20% of patients with the earlier grade of grade A, which I mentioned. But if it's grade C and D, it can go up to about 40%. So there's a high risk of relapse after initiating PPI, on PPI. So that's a problem. And reflux symptoms are not adequately controlled after the first dose of PPI on almost 2/3 of the patient. So it's quite a problem, the relapse with the current dose of PPI. And PPI failure, there will be a group of patients who will have incomplete or unsatisfactory response. Another problem is poor compliance. People don't like to take medication. So often they won't take medication, and that will also cause PPI failure. The other thing which is quite important is the dosing time. The patient often doesn't know when to take the drug. And ideally, the PPI should be taken before food at least 30, if not 60 minutes more. And twice daily PPI is often found to be useful. So if you've started them on once, many will benefit if you're giving it twice. And this is also quite an important factor. A lot of your patients will say there's a nocturnal acid breakthrough. So nocturnal acid breakthrough is defined as a persistent reduction of intragastric pH below 4 for more than 60 minutes during nighttime.
And it can occur up to 40 to 70% of GERD patients. It's quite a large number. So I'm pretty sure all of you will realize the PPIs are often not doing the trick. And nocturnal acid bacteria has been observed in 75% of all individuals, even taking PPI. So if you are doing a 24-hour pH studies, there are many patients who will have nocturnal acid breakthrough and are not having a good sleep. So this is sort of an algorithm which is often followed. It's quite a busy slide. So if you start from the top, you give a PPI course for 2 months. If there's alarm symptoms, you do endoscopy and do accordingly. If after 2 months of PPI dose, once daily, you can go up to another PPI, or you can increase the PPI to twice daily. So switching PPIs can sometimes help. If it still fails, you go do it for an endoscopy, or you go for an esophageal impedance and pH study. If it is negative, you are not showing any active disease, active reflux or high pH, you can try pain modulators like tricyclics, SSRIs, trazodone, and SNRIs. If it's positive for acid reflux, then you try PPI dosing, look at the compliance, maybe add an H2RA blocker at night, try some sucralfate sodium alginate, may need to consider anti-reflux surgery. If it's positive for weak acid reflux, again, anti-reflux surgery and endotheroscopic therapy, you've probably heard of it, can also be done. However, if there is no access to esophageal studies, then you can do independent treatment. But do remember, there will be a group of patients who will benefit from pain modulators, as I mentioned, tricyclics and SSRI. So this is something which we can follow, because there is a large number of patients who are not happy with once dose PPI. Now, you have probably heard of, this is the update, and you are probably all using it already. This is potassium competitive acid blockers, which are more known as PCABs. And what are they? They are a novel, obviously novel class of acid suppressants. They are quite different from PPIs. And the important factors is it has got rapid onset of action, less variability with CYP2, C19 polymorphism, and extended half-lives. What we are using these days quite often is vonoprazan, but I'll show you some data to see where and when I believe that you can use this. So it's a novel orally active drug called PCAB. It was first approved in Japan in December 2024. Japanese were the people who actually started using this, and they used it not only for reflux diseases, they used it for gastric ulcer, duodenal ulcer, and also in patients who had aspirin-induced changes. Subsequently, the USA FDA approved it in November 2023, and they also approved it for treatment of Helicobacter pylori infection. And in India, since last year, it has been approved, and I'm sure all of you have probably used it already. What's the mechanism of action? It acts as the hydrogen potassium ATase transporter system. And I will go to the slide later, which is actually will help to see. So this is what it is. So the conventional PPIs actually work at the H potassium replace thing. But proton pumps are prodrugs. So it actually has to convert to sulfonamides and block the receptor. So the proton pumps are on the top bit. But there will be newly surfaced proton pump sort of receptors where the acid reflux can still happen. But with vonoprazan, because it's not a prodrug, it can actually block the proton pump, the H potassium, sort of the receptor more avidly. So these are the differences. PCABs are not prodrugs, PPIs are. PCABs are more acid stable. It acts directly after protonation, but as I mentioned, PPIs need to be transformed to the sulfonamide to be used. Hydrogen potassium ATase binding, it binds competitively. They bind via sulfonamide. Binding to the proton pump is reversible in case of PCABs. It's not irreversible in case of PPIs. Maximum acid suppression after dosing will start in 1 day. It can take 3 to 4 days. And the important thing is PCABs are meal independent. So it can be had before or after. PPIs, as I mentioned, is meal dependent. Half-life is more for PCABs, and it is not affected by CYP2, C19 polymorphism. And as I mentioned, so these are the basic difference between the PCABs and PPIs. So I'll just go through 4 studies which are quite relevant and which actually tells us why we should be using PCABs. So this came out in 2015, quite a long time back in elementary pharmacology. So it's a very interesting study. So what they did is on day 1, on period 1, they gave vonoprazan for 20 milligram for 7 days, esomeprazole for 7 days, same with rabiprazole for 7 days. There was a washout for 7 days, and then they reversed it. So the people who were having vonoprazan had esomeprazole, and they looked at it, what's happening to the pH. What actually it showed that if you look at vonoprazan, which is orange, that in all the cases from day 1 to day 7, comparing to esomeprazole and rabiprazole, it demonstrated there's a sustained and rapid acid inhibitory effect of vonoprazan compared to esomeprazole or rabiprazole. This was again a very good study. After that, in 2019, vonoprazan versus proton pump inhibitors for healing gastroesophageal reflux disease, a systematic review, a big study. This actually again shows, I won't go through everything. There was almost 4,001 article, and where the analysis was done at 8 weeks, comparing vonoprazan with esomeprazole, rabiprazole, lansoprazole, and omeprazole. What they showed that the GERD healing effect of vonoprazan is higher than at rabiprazole, but not higher than the other PPI. So this is a real-world study. But the subgroup analysis, this is the important one, showed that vonoprazan is more effective than most PPIs in severe erosive esophagitis. So what they are saying is in LA, C, or D, vonoprazan was probably doing better than the other PPIs. But for the early esophagitis, probably everyone, all the PPIs and PCABs were similar. Very briefly, vonoprazan versus lansoprazole for healing and maintenance of healing erosive esophagitis. It was a randomized trial, came out very recently in gastroenterology. They randomized patients with erosive esophagitis with Brono and lansoprazole. After 8 weeks, they randomized it again as a maintenance for Vono 20, lansoprazole 15, and Vono 10. And the conclusion was vonoprazan was non-inferior and superior to lansoprazole in healing and maintenance of healing. I think that was the most important thing, that maintaining the healing, it was found to be useful. And this is the last one, American Journal of Gastrology, 2024 May, comparative efficacy of PCAB versus PPIs for grade CD esophagitis. So these are the ones who have got severe esophagitis, a systemic review and a meta-analysis. Very, very big study. So initial treatment says there were almost 10,000 patients. Proportion of treatment failure was only 6% for PCABs and 21% for PPI. And you can see here on the red dots, vonoprazan was quite high up as effective and safe. And for the maintenance treatment, again, almost 2,000 patients, treatment failure was much lower for PCABs, though you can see it's still quite high, around 21%. So I don't think we have got the whole answer, but that's probably marginally better. And again, you can see below that vonoprazan were doing better than the others. So I'm just briefly mentioned this, as I was saying in USA, this is FDA, this is not a part of GERD, but they are also approved use of vonoprazan for Helicobacter infection. So what are the guideline recommendations? I'm going to tell you about the Japanese guidelines because the Japanese started using the PCABs in 2021. This is the guideline. What they're saying is for severe reflux esophagitis, vonoprazan at 20 milligram once daily for 4 weeks is proposed as the initial treatment of patients with severe reflux esophagitis. I keep saying these are the LAC and D. Vonoprazan at 10 milligram is proposed for the long-term management of severe reflux esophagitis due to the low endoscopic relapse rate. So what they are saying is initiate treatment with 20 milligrams for 4 weeks, maintain it with 10 milligrams. What about mild reflux esophagitis? What the Japanese say that the PPI and PCAB both achieve mucosal healing in the initial treatment of mild RE. Both medications are recommended at first treatment. So for the mild reflux esophagitis, they're actually suggesting you can also use PPIs. PCAB is proposed for long-term treatments of mild RE. So that was a weak recommendation. So when the effect of PPI is insufficient at a standard dose, they are suggesting change to vonoprazan 20 milligram, and that's a strong recommendation. I think that's more or less all what I had to say. Just on summary on the management of GERD, crucially, counseling and lifestyle changes, as I mentioned, weight loss, exercise, proper diet, early dinner probably are quite useful. Empiric treatment, we all do that. There's no harm trying a course of PPI. But of course, you need to keep in mind and take a good history saying there's the worrying symptoms like dysphagia, vomiting. You need to make sure the patient have investigation. Mild and intermittent symptoms, I personally feel simple things, H2RE even, PPIs are good. There is a logic of step-up approach, as I mentioned, giving twice daily dose or giving a PPI H2RAs. In frequent or severe symptoms, PPIs, of course, has got a role, but you may need to consider PCABs. These are possibly patients who have got severe esophagitis, ALS-C and D. And erosive esophagitis, I mentioned also, PCAB is probably the best medication to start. Role of surgery, we cannot deny. So there will be a small group of patients who are not benefiting, and you might need to consider and refer them for further manometry PA studies to see if they're good candidates for surgery. And of course, there are new endoscopic treatment also coming up, which also can help. Thank you very much.
Thank you, Dr. Datta, for an excellent talk. I think there will be some questions from the floor of the House. But just to kick off the discussion.
Should I? It was a very nice lecture. I've got a few questions to ask you. Usually PPIs we give for 6 weeks. Is that okay?
Couple of months. I usually give it 8 weeks course. Yeah.
Supposing some patient has benefited after 6 weeks of treatment with, say, pantoprazole. Now, if that person gets a relapse, when should I restart? When can I restart?
The patients will tell you. I think if the patients have symptoms, you see, PPIs are wonderful drugs. There's absolutely no doubt about it. We always try to stop it, but there will be a group of patients who are unable to stop it. So I think that what we do is the minimal possible dose to control the symptoms. Sometimes I will add a H2 blocker in the evenings, a combination of that, and that sometimes helps. And try and think about lifestyle changes. But if it continues, if the patient has persistent symptoms, you might want to do an endoscopy to see if they're developing Barrett's. If they are still continuing, you might need to consider a manometry or a pH study to see if any fundoplication or anything will benefit. And one thing is also, remember, there are a lot of people do have some functional symptoms with this also. For example, the endoscopy is normal. You don't see any erosions. And manometry may or may not be possible to do. Sometime adding a small tricyclic or SSRIs might be of benefit.
That's right. Thank you. And one or two more. Which is better? Giving a PPI in the early hours and then an H2 receptor at night for nocturnal acid reflux, or what you just mentioned, that some sort of raft, that alginate. Is that better or H2?
I think whatever works for the patient. I think whatever works for the patient. So a lot of people will benefit from 2 doses of PPI. Yeah. But in between, the sort of antacids will also be quite beneficial at times. So in between taking antacids is no harm.
Okay, thank you so much.
I have one question. There was a black box warning for PPI that if you use for prolonged, you can have hypomagnesemia, and that can be fatal at times. This new molecule, do you have that same side effect? Or?
We do not know, not documented, of hypomagnesemia.
I'm told by the organizers that there are some questions from the satellite centers.
Yeah.
Fire away,
so
but then we will take some questions.
We have some questions from Siliguri team. So I request Siliguri, please unmute yourself. Yeah.
Sir, as far as the helicobacter eradication is concerned, which you think the monoclonal is better or PPI, and what is the mechanism? And another question, the same question. the long-term use of the PPI may cause the deficiency of the calcium, magnesium, and also the deficiency of the intensive practice. I think what is the side effects of which is better in this aspect, the vonoprazan or PPI, which is causing less side effects?
So vonoprazan is still quite a new drug. You see, I think it has been approved only in a few years' time. What I personally feel that in patients of severe erosive esophagitis, there is a role of PCABs. And if the patients are not benefiting from PPIs, there's no harm in GERD patients trying a lot of PCAB. Regarding the side effects, I think time will tell. Same with PPI. I think it's very easy for us to say to stop the PPIs, but often patients become dependent. There is a sort of acid breakthrough when you stop it. But of course, we will try and give the minimum dose possible to control the symptoms.
In endoscopy, we usually see that there is something hiatal hernia along with esophagitis or erosive enteral gastritis. What is hiatal hernia? How is it managed?
Very difficult at times. I think if this is a small one, the first thing I would say is lifestyle is very important. So try and reduce the weight, exercise, make sure you are eating on time, do not have dinner very late, raise the head end of the bed up. But you see, if the patients, what I ask the patients, if they're having volume reflux, so it's not only the acid, if they're actually getting the food coming up. So the sphincter is not working at all. And in those cases, manometry, pH studies, and possibly surgery. Because there is no medication which is going to cure the hiatus hernia. And if the patients are giving very good symptoms of volume reflux, do think about further investigations and maybe think about surgery. But lifestyle, again, is very important.
Patient is usually afraid of surgery.
No, I understand that.
What is the outcome of surgery? What is the...
No, there are, you see, now there are endoscopic surgeries are there. We are not referring all the patients for surgery. There are very select few who will need it. But there has been excellent results with laparoscopic fundoplications. Nowadays, our junior colleagues, I don't do it myself, are doing a lot of endoscopic procedures also, poem and stuff. But again, we know there are people who have really benefited from laparoscopic fundoplication at the right hand. But again, very few people will need it.
In your slide, you have put sucralfate and alginate at the same side by side. But regarding sucralfate, I have the question. That is, it doesn't give the advantage of the rapt. So acid may come in the esophagus. Secondly, the mechanism of action, as we read in our pharmacology class, that is, it depends on the action. Action depends on the presence of acid. So should we use sucralfate in case of GERD?
I think it's a very good question. You see, sucralfate acts against the bile better. And there will be a group of patients who will not only have acid reflux, but biliary reflux. And it's often very difficult to dissociate, especially in obese patients. I think there is no harm trying sucralfate if nothing else works in addition. It's not going to do any harm. So I am very happy to use sucralfate.
If I'm allowed one question, realistically, if you are comparing the PCABs with PPIs, I mean, realistically, the indication are only two, isn't it? Los Angeles grade D esophagitis and Helicobacter. Because the trial recommendations are very weak. Those trials are really pharma sort of trials, aren't they?
I never disagreed with you, Somnath, but I think there is some good evidence with LSC and D erosive esophagitis. And I think there is no harm in GERD where there are not many drugs to have more drugs to help us out. But PPIs, yes, absolutely. Stood the test of time. Thank you.
What is the rationale of using combining domperidone with PPI?
I couldn't understand.
Comparing domperidone with PPI.
Yeah. I think you can use any prokinetic with the PPI. I think especially in patients who are having dyspepsia, bloating symptoms, a history of sort of delayed gastric emptying, yes, prokinetic can be used.
My question from my side is, sir, so many patients come to us they have taken 10 years, 5 years, taking PPI. And also they defaulter. Then what is the message for them? And what we can manage that case? And what is the side effect? And what is for long for that side effect?
It's impossible to manage. I think if someone has been PPI for so long, they really struggle to stop the PPI. But again, what I will always say, try to take the minimum possible dose. And sometimes I will try and reduce the PPI and add an H2 blocker and try and ask them to use some more antacids. Actually, sometimes I will use some sort of antidepressant, tricyclics and things of that, depending on the patient. But you see, all of us know that. I think there are people who will really struggle to stop PPIs. And I think we have to try and look at other things to see if we can do and help them.
I think in the interest of time, we have to wind up this session much as I would like us to continue. And thank you, Dr. Dato, once again for an excellent talk.
Thank you. Thank you very much.
Fatty liver disease. The fatty liver disease is the most common cause of chronic liver disease and the prevalence of which continues to rise. The high socioeconomic burden of fatty liver disease, it poses a great global health challenge. Now, an approach to fatty liver disease for the topic. May I request Dr. Ashokananda Kunar of Peerless Hospital? So please, and Dr. Dilip Todi of Narayana Health Hospital to chair the session, please.
Computer change projection. Before I start my deliberation, I would like to just I would like to congratulate Sun Pharma really to organize this symposium today, not only in Calcutta, but throughout the Eastern India. I think we should all give them a big hand so that, you know, without the participation, this is impossible. So I think I must congratulate the Sun Pharma to do this. No, I can't change. Take it. Wait. এটা একটু দিন তো ঠিক আছে এটা এসে গেছে না এটা পরেরটা এটা না So I think we all know about the epidemic which started with Dr. Sujay Ghosh, where he mentioned that, you know, there is an epidemic of obesity, epidemic of diabetes, epidemic of cardiometabolic diseases, and as part of it is fatty liver. So in fatty liver, we know that this is worldwide, this is one of the very latest epidemiological picture where we can see what is most surprising, that we used to know that obesity and fatty liver disease is more common in Western countries with obese people. But if you look at this cartoon, that one can see South Asia has 33% of people having fatty liver, and in North America is 31%. So that shows that it is present throughout the world. And why it is important, that will come to in a bit of time. The new approach has been to actually not to use the term fatty liver. They said it's a kind of stigmatization that, you know, you call somebody fatty. So the steatotic liver disease is the new name. And we know that hepatic steatosis is usually seen during the liver biopsy, however, which is not possible. So we depend on imaging for any evidence of any fat deposition in liver. Presence of any cardiometabolic criteria, that is the first thing to look for, and also to look for the history of alcohol. If we have a alcohol of more than 50 grams in ladies and 60 grams in men, then it becomes alcoholic liver disease. If not, they are between 20 and 50 or 30 and 60, then it becomes a combination. And if we have no history of alcohol, then it becomes a metabolic dysfunction associated steatohepatitis, which we all know is called MASLD or MASLD and MASH. So what is the prevalence in US? Because they have the data, and it shows that not only in ultrasonography, but if we look at these fibroscan findings, and it's around 34% of steatotic liver disease, of which 31% is MASLD and MAT-LD is 2.2, and alcoholic liver disease is really quite low, that is less than 1%. NAFLD, the old classification, and MASLD, actually they match very well in 99% of patients. That the old classification and the new classification is 99% concurrence is there. But what is important is, as has been highlighted by Dr. Sujoy Ghosh in the morning, that the global increase of obesity and other risk factor, we know there is an increased rate of NAFLD, but at the same time, one should also remember that this is a multi-system scenario with cardiovascular diseases, increased incidence of kidney problems, and so it is a problem of multi-system involvement. And this actually summarizes that if we have the liver inflammation, also there is systemic inflammation, which causes stroke, myocardial infarction, kidney disease, and also non-liver cancers. So there is a suggestion that this metabolic dysfunction associated steatotic liver disease also increases the risk of cardiovascular disease. So this slide actually shows a data from Asian country, from South Korea, where we can see the muscle-directed SLD, and if there is a no MASLD, there is a huge difference in the incidence or cumulative incidence of cardiovascular events. So this is closely linked to cardiovascular events, and which may determine the course of the disease in a particular patient. And recently it has been shown that MASLD has a huge additional diagnostic criteria are there, like diabetes, kidney disease, hypertension, and cardiovascular disease. So one must consider the other aspects of MASLD as well to define the risk in a particular patient. So I will just show the natural history that if we have NASH or an advanced phase of fatty liver disease, there will be fibrosis in 40 to 50%, and 20% will go to cirrhosis. That means not everybody goes to cirrhosis, only 20%, and they will probably require a 20 years time. There is, the top part, it is written, the fibrosis progression in NASH is one stage in about 7 years. And 20% patients are fast progression and they go to cirrhosis. But risk of death, if you look at the bottom part of the slide, there is CVD, that is cardiovascular disease, non-hepatic cancer, and third is liver. This is similar in Asian countries. This cartoon actually shows the evidences from Asian studies, and one can see that there is a to and fro journey, that from normal liver to simple steatosis to NASH and fibrosis and to cirrhosis, and there is reversal also. Also, we know that 1 to 4% of patients may go into hepatocellular cancer, but if you look at even without going into cirrhosis, there will be evidence for liver cancer. So liver fibrosis is the main feature which determines the outcome, especially the liver-related outcome in patients with non-alcoholic fatty liver disease. And this is a slide which summarizes that if you have a very high degree of fibrosis, that is F4, then there is 47% risk of liver events. This has been shown by other workers as well. The all-cause mortality and liver-related mortality all depends on stage of fibrosis. So how do you do that? How do you assess? This is a recent publication in New England Journal by Dr. Sanyal and group. They have shown that for all the outcomes like death, like hepatic decompensation, like liver cancer and extrahepatic cancer, the stage of fibrosis is the most important factor. The stage of fibrosis here is in the F4 fibrosis is in yellow, F3 is in blue, and F0 to F2, which is called minimal fibrosis, they are the black ones. And you can see for all these outcome, the stage of fibrosis is most important. This cartoon actually showed, this is an old slide from New England Journal in 2017. In United States, they found that 25% has fatty liver, that means 1 in 4. Then 5% will go to NASH and 1% will go to cirrhosis, and of which some patient will go to HCC. So NASH actually, though we look at the ultrasonography, we know that the ultrasonography tells us grade 1, grade 2, grade 3, but basically it was actually dependent on the liver biopsy, where we can see that steatosis less than 5% is grade 0, and grade 3 is 66% of cells will have liver fat. And the fibrosis is again stage 1 to stage 4. So now how can we actually detect it without doing a liver biopsy? That is the main purpose of today's discussion. Ultrasound is, as I was telling, it's semi-quantitative, is not very good. FibroScan can give us, that is more than 288 causes that there is a fatty liver. But the best way is to look at the MR scan, that is MRI PDFF, which is actually more than 5% is definitely shows that there is evidence of fat in the liver. And this is a busy slide, but I would like you to highlight a few things. One can do a FIB4. FIB4 is a test which we can do on our day-to-day smartphone application, that if it is more than 2.6, then there is a likely of fibrosis. Then in imaging, if you look at the FibroScan, then there is a cutoff of 8, which says if it is less than 8, it is unlikely, and if it is more than 12, this is there is a possibility of liver fibrosis. And for advanced fibrosis or cirrhosis, again, FIB4 can tell us that there is a possibility, and this FibroScan and MR group is much better in identifying advanced liver fibrosis. So once we get a patient of fatty liver, we can look at diabetes, obesity, cardiometabolic risk factor. We can calculate FIB4. FIB4, if it is less than 1.3, then we probably will be much better to reassess FIB4 every year or every 3 years. But if it is more than 2.67, then there is a chance of advanced fibrosis and should be referred to a hepatologist or a gastroenterologist. And in between needs a second test, which is best done by a FibroScan, and that can identify patients who probably have moderate to severe fibrosis. And this is the same thing published in from American Journal of Gastroenterology, American AGA, that is identify patients at risk, history, laboratory test, FIB4, indeterminate risk, you do the LSM. If it is very high, then you go to the liver specialist. And if it is less than 8, I think we don't have to worry about these patients or needs any drug treatment. I think then if we look at these are the assessment of non-invasive assessment of liver fibrosis. and this is vibration controlled transient elastography or fibroscan and magnetic resonance elastography. And this slide shows the different images of which transient elastography has now been looked at the standard protocol, and for research it is the MR elastography. This we can see, the bottom half is transient elastography, where we know the 8.2 is the factor where there is a start of fibrosis, second stage, and the MR is around 3.35 kPa. So they are almost equivalent. So what it has been shown by the ASLD that for these are the limitations, but in accuracy wise, MRE or the MR based test is the most accurate, and fibroscan is the, I mean, the ease of use and accessibility is much better. And so we know that the hierarchy based upon evidence is FIB4 is better than the rest of blood-based test, and fibroscan is better than FIB4, and this MR-based test is better than a vibration control elastography. So what is magnetic resonance elastography? That can also help us in selecting our patients for treatment or assessment, because if we see that FIB4 is less than 1.6, no need to second screening. But if it is more than 1.6, then one can do the second test with MRE, and MRE can tell us this, there is a, if it is less than 3.3 and FIB4 less than 1.6, then there is a negative predictive value is very high. And for rule-in, that means where MRE is more than 3.3 and FIB4 is more than 1.6, positive predictive value is 95%. So you can positively diagnose that this patient has a advanced fibrosis and needs immediate treatment. And now by the liver stiffness by magnetic resonance can also tell us that if you have a MRE of 5 less than 5, then probably there is a less chance of hepatic decompensation. But if it rises further, there is chances of hepatic encephalopathy varices that may need treatment. There is another way of looking things is the Baveno classification, where again the same thing is done. I have just summarized here. There is 5, 10, 15, 20, and 25. That on fibroscan, which is easily available in the city now. So you can, if it is between 10 and 15, then you select those patients for treatment. And if it is 25, then it's cirrhotic. So we don't know exactly whether the treatment will be beneficial. But between 15 and 20, also we think this is the patient where we assume they are ruled in for advanced chronic liver disease. The other scores are also available, but I will skip that for time. I think we'll go to serum ferritin. Serum ferritin is a simple test, but it can be very helpful in this scenario. We know that the serum ferritin can also predict over a period of time. The serum ferritin, the red one is extrahepatic cancer, and the blue is the liver related. So with the ferritin percentile, we can predict that these patients may develop advanced liver disease and needs treatment. So also if we combine ferritin with FIB4, they also are helpful. So that is the recommendation from ASLD that we can do the fat and stiffness mapping before and after treatment. So this is efficiency. This is very good for clinical trial because we do not require any histological criteria or biopsy, which is refused by most of the patients. So I would like to summarize saying that when you come across a patient of NAFLD or MASLD, we know there are two stages, non-fibrotic and fibrotic. If it is fibrotic, then there is fibrotic NASH, advanced fibrosis, cirrhosis, and there is chance for liver cancer. So the main thing is about lifestyle modification, which is applicable for all stages, close follow-up for NASH patient, and pharmacological therapy is only indicated where there is fibrotic NASH advanced fibrosis, and in some cases in cirrhosis. Cirrhosis, they require intensive management for complication and HCC screening. So this is my ultimate slide where the takeaway from today's discussion is that therapeutic approaches is changing very fast. We have few things that we want to achieve. One is liver fat reduction. That has been summarized by Dr. Sujoy Ghosh in the morning. That is one of the most effective way of decreasing the liver fat. Second is NASH resolution or improvement. That means where we want to reverse the fibrosis. The main group of drugs that is available to us is basically the PPAR agonists like saroglitazar, incretin receptor agonist, and recently approved by FDA thyroid hormone receptor beta agonist. And lastly, the fibrosis improvement or cirrhosis reversal is the most difficult thing, and it has not been shown in any of the clinical trials where there is reversal of cirrhosis. So I think for the time being, our approach to patients with fatty liver or metabolic associated steatotic liver disease is to assess them for fibrosis and look at the other parameters for cardiovascular disease and also for kidney disease. Try to holistic management is the outcome, not to just prescribe drugs. And most of the drugs can only help if you have achieved lifestyle modification. Rarely we can employ bariatric surgery, and now there is endoscopic bariatric procedure. But as Sujoy has highlighted in the earlier session, that today I think drugs are going to achieve what bariatrics can do. But the main thing would be the lifestyle modification and application of newer drugs with caution. Because one thing is certain that these drugs has to be continued for many, many years, like diabetes and hypertension. So the drugs must be safe and must be effective, and drugs must be combined, because one drug might reduce the fat, the other drug might reduce the fibrosis, and another drug like SGLT2 inhibitor that can also change the cardiovascular mortality. And we should be careful about occurrence of cancer in certain situations. Thank you for your patient hearing.
Thank you, Ashokda, for your excellent deliberation. The floor is open for question, and if anybody has any question.
Any questions from the locations? You can unmute yourself.
Hello. Hello, sir. Amitabh. Besides in the blood, is there any role of, often we monitor the platelet count? We know there are lots of causes of thrombocytopenia, and having excluded all those causes,
I think it's a very important and very relevant question. But because many patients come to us after visiting the hematologist, and but the FIB4 itself, why FIB4 is important? FIB4 is being propagated as the basic test because FIB4 has SGOT, SGPT, platelet count, and age. So FIB4 actually is relying mostly on SGOT, SGPT ratio that we used to know. We used to do that in clinic before a FIB4 came, and the platelet count. So that shows that this is very important. That is a marker of actually liver dysfunction and basically portal hypertension.
Another relevant thing is that even patients with Helicobacter pylori also develop thrombocytopenia because of autoimmune hemolytic anemia. That is one issue, because once we get thrombocytopenia, we must see that whether the patient has Helicobacter pylori, because if the patient is already on PPI and we are doing breath test, that can be false negative. So this is one thing that has emerged. I think in the last edition of Harrison also it has been mentioned. So thrombocytopenia has an association with Helicobacter pylori. It causes autoimmune hemolytic anemia, and often we miss it in breath test because already the patient is on PPI. This is one point. Another thing is that we often use vitamin E in the treatment. It's a very cheap drug. When I was reading in some paper that vitamin E prolonged use can cause intracerebral hemorrhage.
No, these are all well-known toxicities. Vitamin E has two problems. Na? One is hemorrhagic stroke and one is your bladder cancer on prolonged use. So that's why people are using it before these drugs were available. But today we are not discussing the drugs. We are just approaching that, not treating everybody with drugs, but mainly be vigilant about the other organs, and secondly, think about the lifestyle modification which has to be continued throughout the course of patient's life, and drugs used to be judiciously, and because it has to be used for years.
Thank you, sir.
Arekjan achen.
I'm Dr. Mukherjee. I personally do endocrinology. This regarding saroglitazar, it is the new recommendation in the MFLD, because in previously when the saroglitazar was launched, it was the medicine recommended for this triglyceride reducing drug. Then the problem is that this 4 milligram of saroglitazar, the moment it is stopped, the triglyceride level rises. But in case of this fatty liver, actually, what should be the dosage schedule? Whether it should be continued uninterruptedly or it cannot be titrated because the tablet is not scored also. So how long to continue this medicine?
Actually, saroglitazar is available initially for high triglyceride, and it was diabetic dyslipidemia was the indication, and it was launched as a drug for diabetic dyslipidemia. But once it has been shown that it has been shown to reduce liver fat. What is not sure that whether they really reduce fibrosis. But there are several studies that there is transaminitis is gone down, the liver fat is going down. So that's why the saroglitazar has been taken it has to be taken indefinitely. Actually, there is no trial showing that the saroglitazar can be stopped. The second thing is there are more drugs coming in the same branch, which is lanifibranor, which is all the PPR delta, alpha and beta agonist. So I think the PPR group has to be there because most of the patients have diabetes and most of the patients will have dyslipidemia, and also it has a good effect on liver like SGLT2 inhibitors and others. So these drugs once started, I think there is no reason because they are also very safe. Saroglitazar doesn't really have a long, bad side effects. This is being used for at least 5 to 6 years now, but we don't have a study on hepatic fibrosis. That is the only problem.
Thank you.
One small question. You have told that lifestyle management is the key management. But what about lean NASH? We are getting around 5% patients who are non-obese, but still having definite.
Lean NASH is also initially, though it was present in most part of the world, but it is more common in the Asian continent. Lean NASH also has the main mechanism is again the insulin resistance. So they are saying the modest, modest weight loss. And here also there was a study initially which says that the lean NASH, they have worse outcome. But later on, there are studies from Hong Kong and other places where they showed that the lean NASH is not really worse, but it has a similar of complications like progression to cirrhosis, and maybe that these patients are not different, but the lean NASH they are not different from the obese NASH, but here they are metabolically different. So that means the mechanism is similar, So drug treatment is also will be similar, but here no one is saying that you would be losing 10% of body weight. I think modest exercise and to try to address the insulin resistance should be the main thing.
Thank you, Ashok. The last question. You see, because there are a lot of practitioners here, you see prescriptions prescribed giving UDCA, ARSO. Any comment on that?
Ursodeoxycholic acid, actually, initially there was no drug, so ursodeoxycholic acid was being used. However, ursodeoxycholic acid, even high dose ursodeoxycholic acid plus vitamin E has been tried, but really it has not been substantiated. And at present, ursodeoxycholic acid is not recommended for NAFLD.
Thank you. Thank you, Dr. Ashok. Thank you.
কেউ কিন্তু আধ ঘন্টার বেশি নেয়নি 20 minutes হয়েছে। চলো পরে যাচ্ছি। আচ্ছা
Now, coming to the last session of today's evening, may I request Dr. Ajay Krishna Sarkar, sir, from PLS Hospital, to take up a discussion on a very interesting and challenging case of pyrexia of unknown origin. May I request Dr. Narayan Banerjee of Fortis Hospital to chair the session, please.
I think Ajay doesn't need any introduction. He is the head of the department and the clinical in the department of critical care medicine and general medicine. May I request Ajay to start his session?
Thank you, Narayan. I'm just going to discuss one case. It's a PO, but it has got a lot of facets. So I think it will be at the end of the discussion. It's an interesting one. This is my patient who was a 57-year-old male. He resides in Dhanbad and is a professor by occupation. Actually, he was running temperature for last 14 days before admission to our hospital. And he was associated with vomiting, nausea, dizziness, loss of appetite, all constitutional symptoms, nothing very specific. And the clinical examination was uneventful. We couldn't find anything wrong with him. So initially he was admitted in Dhanbad Hospital and received antibiotics, cefoperazone sulbactam for UTI, and they could identify Klebsiella, which was ESBL positive, and also he has got some hyponatremia, for which he was getting some treatment. And finding no improvement for next 48 hours or 72 hours, they have decided to shift that patient to PLS Hospital. And after getting admitted in our hospital, we continued the same antibiotic because we don't know what exactly we are dealing with. So let's go for ESBL. They have identified, continued that. And our all battery of tests, including chest X-ray, USG, whole abdomen, echocardiogram, CBC, renal function test, liver function test, electrolytes were within normal limit. Just I'm highlighting the total count because there is some reason for that. Look at this lymphocyte, neutrophil lymphocyte ratio 1.8 and platelet lymphocyte ratio 88. So this is has got some importance when I'll discuss later on. Besides that, blood culture in our hospital were negative. We couldn't find anything. And also, as we all do in any PUO, a battery of tests, including brucella, scab typhus, dengue, malaria, leptospira, everything were not negative. So patient was initially afebrile for a couple of days and after admission, and he was having persistent, asthenia, lethargy, no teething at all, and very, nauseating, vomiting. So whatever he is getting into his stomach, coming out. So it's a challenging for us to continue his treatment. So we thought, let us take the calcium. It was 12 milligram, quite high corrected calcium. So that was our thought that could be this is because of that. And we looked for hypercalcemia. So parathormone was normal, vitamin D was not high, rather low. And we thought that if we correct the calcium, probably he'll be asymptomatic. So we have started on him zoledronic acid and also corrected the calcium. Still, he continued to have the symptoms. And then we looked for, serum protein electrophoresis is a standard, protocol for any hypercalcemia, and which came out as positive. So M protein was there. So we thought that we have made the diagnosis, so went for bone marrow study and myeloma study skin, but both were negative. So his bone marrow was showing only 6% plasma cells. So if you go by the myeloma classification, so he might fall into the group of MGUS, where you will get the monoclonal antibody. You might get some antibody, but bone marrow will be less than 10% plasma cell. And MGUS doesn't have any practically symptoms. They don't have too much symptoms. So that's probably is not our case. So then as a PO investigation, if you go through Harrison, first line of investigation is PET scan. And we did the PET scan to find out whether there was any mitotic lesions hidden anywhere or not, which might have caused hypercalcemia or something else. And the PET scan reported, as I'll show the report, then I'll come to that previous slide. It says that I'll go from down, no metabolically active disease. That means there is no malignancy, first thing. Mild bilateral pleural effusion, you can get it in a normal person, doesn't have any significance. Fracture in olecranon process with evidence of inflammation. That is one positive point in PET scan. Evidence of synovitis in bilateral shoulder, hip, and in a elderly, not elderly, middle-aged patient can have this thing. So, and the significant perinephric fat standing and mild thickening of renal fossa, which also is suggestive of UTI, and we have already treated him for UTI. So coming to this, then we thought, let's go for ANA profile as well as C and Priyanka, because there was some suggestion that mild patchy FDG uptake along the wall of the aorta and the brachiocephalic artery, as well as common carotid and common and external iliac artery. So large and middle vessels arteries are having some deposition along their wall. So is it vasculitis? So that was one suggestion, and that can have PO. So we looked into that ANCA, and which was negative. So now question is olecranon fracture. That was ruled out by doing MRI scan as well as X-ray. I'll show to that scan. But the MRI has shown some infective focus in the olecranon process. So we took the biopsy from that olecranon process, TrueCut biopsy under CT guidance, and that showed granulomatous inflammation. I'll show that slide as well. And also grew some MSSA. But when we looked into the gene expert for MTB in that material, it was negative. And the gram stain, there was no gram-positive organism. Possibly this was contamination. And AB stain was also negative. So far we have granulomatous lesion, one positive findings in one area. Now, this is the, our picture one showing T2 sagittal section where the olecranon process, any pointer? I don't know. So that olecranon process is there, and after contrast, it has been the contrast has shown some exaggeration of that lesions. So we took the biopsy from there. This is a true cut biopsy under CT guidance from that olecranon process, and the biopsy showed granulomatous lesion. This is a beautiful granulomatous lesion in the 3 slides showing that. So it's a question is now, patient continued to have, fever, again, with high fever and vomiting, and is very asthenic. So we thought, is there any something endocrinal things going on? So we checked the cortisol level, and the cortisol was, as you could see, very low. Our level is normal 4 to 6, and it's less than even 2. So we did the ACTH stimulation stage. ACTH was also low, and the stimulation didn't improve much of the cortisol level, which should have been at least 3 times higher. Normally 6 or would have been 18. So we have got adrenal insufficiency and also some suggestion of pituitary involvement. So MRI pituitary was done. So MRI pituitary was clearly shown that the atrophy in first picture is showing the atrophy of the pituitary gland with empty sella, and with contrast, gadolinium contrast, there is increase of the pituitary, and the empty was picked up with CSF, white, the arrow was showing. So it's a pituitary involvement. Now, what could be the cause of this patient? So just to summarize, 57 years gentleman having fever for nearly 1 month by this time. And so far, we initially had an impression of a myeloma that has been ruled out. Then we thought it could be because of some inflammatory granulomatous lesion involving that, and that could be so far the reason for our subsequent test or subsequent discussion. So granulomatous disease, now we have few causes. First, tuberculosis. Is it a tuberculosis? Very unlikely, because we haven't got any suggestion except for granulomatous lesion. So second is sarcoidosis. Could be because we have, after that granulomatous, we checked the AC level, which was high. So it could be sarcoid. I'll come to our discussion. Second is fungal disease, because histoplasma and coccidioidomycosis can be the cause for PUO. At least I have 2 patients who had histoplasmosis, and it's quite common in our peri-Ganges areas. So it involves the adrenal gland, but that will cause primary adrenal deficiency. In our patient, adrenal deficiency is secondary, involving the pituitary. The ultrasound of adrenal was absolutely normal. So it's unlikely, though galactomannan was high. And we all know galactomannan can be false positive in many conditions, including sarcoid, including tuberculosis. So granulomatous vasculitis like Wegener's can cause granulomatosis, and along the vessels he had some PET scan suggestion vasculitis, but ANCA were negative. So unlikely that. So could it be a case of sarcoidosis? So far it's fitting with our, but what is sarcoidosis? We all know it is a multi-system granulomatous disease involving many organs. But interestingly, 90%, more than 90% lung or thoracic organs are being involved. And our patient did not have any thoracic or lung involvement. So, and sarcoidosis is still we don't know the pathogenesis. But what we know that it's an abnormal immune reaction between 2 things, host or genetic factor one way, and the environment and infection one. So infection can lead to sarcoidosis, or any environmental changes can lead to, or genetic factor. But coming to our, diagnosis, ATS guideline according to 2020, there are 3 points. One is presence of corresponding clinical symptoms. If it affects your eye, there has to be some uveitis. So symptoms has to be there first, and we have symptoms of PUO. And second is discovery of non-caseating necrotizing granulomatous lesion in at least one or more than one. We have that. So that 2 points are there. Third is very difficult, exclusion of other causes of granulomatous disease. It's very difficult because if I say, this is sarcoid, one can say, why not tuberculosis? Why not histoplasmosis? So it's very difficult. So that is the problem with ATS diagnosis, because its symptom is very non-specific, and I was just going through literature and I find this word very interesting, and that's why I've quoted. Sarcoidosis is often called the big imitator and is considered to be a chameleon diagnosis because it can be disguised as another disease and you don't have any ideal biomarkers or any imaging test for sarcoidosis so far. So still it's an enigma in our case. When we can suspect sarcoidosis, obviously, you need to have a high index of clinical suspicion, because in your PO case, always you must think about this. Pulmonary system is involved, as I mentioned, in 90% cases. And if you have a patient with cough, bilateral lymphadenopathy with PO, then sarcoid is a possibility. But again, TB, cancer, lymphoma, all can have that fever with bilateral. Even histoplasma can have. Even prolonged treatment of steroid can cause bilateral lymphadenopathy. So these are the non-specific ones. But what is very specific? Non-caseating granulomatous lesion. That is the gold standard to identify sarcoid. But granulomatous lesion again can be in other areas. So biomarkers, just going through quickly, we considered, serum AC and interleukin-2 receptor. These two are considered to be the most important biomarkers. But if you go through the literature, they are not the specific or sensitive. Even they are only when you have more than 2 times. Our case had nearly 2 times, but this can be increased in many conditions like lymphoma, diabetes, chronic liver disease can have, and tuberculosis. AC is high. So I was just going through literature, as I said, and I find that this is very interesting one, that chetotriosidase, neopeptine, and serum amylase. These are the biomarkers for sarcoid, and very specific one is chetotriosidase. Is very specific. I don't know whether we can measure this one, but this is the information I gathered from recent literature. And it can be very sensitive and specific. Only thing, it can be positive in asbestosis and non-sarcoid pulmonary fibrosis or lung cancer. Bronchial lavage, we do all, because if you have a pulmonary involvement, you have to do lavage and see lymphocyte count. It has to be more than 15%. And the CD4, CD8 level, if you can measure, CD4 will be higher in sarcoid, CD8 will be lower, and the ratio will be always high, more than 3.5. That is very important biomarkers for sarcoidosis. But our case we didn't do because there was no suggestion of the lung involvement. And other biomarkers, like I have mentioned, that please look into that platelet lymphocyte ratio. This is another very good biomarker for lung involvement of sarcoidosis. When you have lung involvement, it should be more than 158. But in our case, it was nearly 88. The other one is lymphocyte, neutrophil lymphocyte ratio. These are cheaper thing anybody can do. If you have a lung sarcoidosis suspicion, just look into this. And if you have that more than ratio of NLR more than 2.2, then it's almost more than nearly 90%, 85% sensitive and specific. It's very important biomarkers. Calcium, we all know there are a lot of fallacies with calcium, and we do calcium, but we don't see the calciuria, which is more important than calcemia, hypercalcemia. Please look into the calciuria level. This is all about calciuria. Now coming to the scan. radiology, CT scan we all do for sarcoid, pulmonary sarcoid, to see lymphadenopathy, to see the lung involvement, fibrosis, reticular pattern. Apart from other things can happen, I'm not going into that. But always try to remember that when you see the lymphadenopathy, just look into the character of that lymphadenopathy, whether it's a fused or it's a discrete, the enhancement is uniform, or the enhancement has got some pattern, because that will tell you that what exactly it is. Like when you see there, see enhanced, in case of sarcoid, it will be diffusely enhanced. But in malignancy, there will be hardly any enhancement. But in lymphoma, there will be some enhancement. But in tuberculosis, it will have a ring-like enhancement. So it's very important when you see the lymphadenopathy with some POKs. PET scan, we haven't done CT scan because we went for PET scan. And if you do the PET scan is much better than CT scan in terms of identifying or diagnosis in a case, because PET can identify very small lesion. It also can identify the area where you are going to take your biopsy, and also for follow-up. And our case, we have taken the biopsy from that area of oligoclonal process. And another is MRI. Only MRI should be done when you suspect cardiac sarcoid, because in gadolinium, we call it late gadolinium enhancement. LG, in cardiac, this will have a discrete pattern, 3-layer. But if you have a MI, then it will have a confused, the whole layer will be involved in that. Another interesting thing is cardiac sarcoid, that if you have a ischemic change in thallium scan, you'll have a less uptake thallium, but in sarcoid, uptake would be higher. That is one thing. And we also do MRI for neurosarcoidosis, because neurosarcoidosis, there are a lot of changes can happen, as I have mentioned, from leptomeningeal thickening, tumor-like lesions, cranial nerve, gadolinium enhanced pituitary lesions, and our case had that. And MRI also has good to showing cranial nerve involvement. Coming to our case again, then is it a case of isolated extrapulmonary sarcoidosis? This is another thing, because he doesn't have any pulmonary involvement. That is 100% sure. So is it a isolated? So let us see what is isolated. Isolated pulmonary sarcoidosis can happen in less than 2%. It's not, should not be 5, less than 2%. And our patient had fever, hypercalcemia, non-craziating granulomatous lesion, high serum ACE level, suggestive of sarcoidosis. Still, we don't know. Suggestive. There was no pulmonary involvement, but he had 2 organ involvements, pituitary as well as bony involvement. So 2 organ involvement. Let's see what are the organ can happen isolated. Neurosarcoidosis, cardiac sarcoidosis, skin, neurocardiac skin, and then bony, eye, and thyroid. Thyroid, only thyroid, there are cases reported thyroid gland is involved with sarcoidosis. Thyrotoxicosis presentation was that. So we were almost sure that our case was a isolated extrapulmonary sarcoidosis. Then we put him on steroid, prednisolone, not more than 30 milligram, because there are a lot of doses with sarcoid steroid. But believe me, there was a review article in Lancet was showing that even 20 milligram is good enough. So we started 30 milligram, general conditions started improving. Patient became afebrile within a couple of days, and he went home with asymptomatic state. And we are planning to do repeat MRI of the pituitary gland and oligoclonal process in his next visit. He has been discharged in last 2 weeks back. So that is all about my case. What there could be any questions or any suggestions, floor is open. And
thank you. What I want to say that granulomatous lesion with hypercalcemia, it raises the suspicion of sarcoid, because in multiple myeloma, you won't get hypercalcemia unless there is a fracture. That is the thing. So in a FUO patient who is having some sort of vasculitic like lesion with high ST and granuloma, I think that is the key and key thing for your diagnosis, but it's a real diagnosis.
One question.
I couldn't hear. Now, reason for presenting this case is that we all know sarcoid, and if there is pulmonary involvement, it comes immediately in our mind. But isolated, extra pulmonary sarcoid incidence is 2%, and it's a rare, very rare. Where if you go through literature, hardly you will find cases over there.
Ojeda, what was the potassium level of this patient? Because this raises a suspicion of Addison's disease. Because this patient presented as a crisis of the Addisonian crisis sort of thing. When you gave the patient steroids and the patient improved. So why not tubercular Addison's disease could be suspected in this sort of patient?
Tuberculosis can happen to any organ, that's true. But in this case,
in India, the Addison's disease, the incidence is mostly with tuberculosis.
No, this is not Addison, it's a secondary. It's not primary. Our FSH, LH, everything were on the low normal. Everything.
I wanted to know about the potassium level of this patient. This was
potassium was nearly normal. I haven't mentioned because there are a lot of, your limited time. I have said these were within normal limit, means normal.
And another thing was there multiple blood cultures were all negative, I presume. Infective endocarditis was ruled out because this oligocrenon process can be a
good question. Infective endocarditis, now we don't go for transthoracic echo. Sorry, transesophageal. PET scan can identify a small vegetations. So PET was absolutely normal. So that's ruled out. Infective endocarditis. Second point, what you have said.
Tubercular Addison's, I thought.
Tubercular Addison's, as I have mentioned, that tuberculosis, there was no, except the granulomatous lesion, there was no suggestion of tuberculosis.
And histoplasmosis, which you said that.
Histoplasma could have been, but as I have said, the ultrasound in histoplasma adrenal always will be big adrenal. It's more than normal size. And we did repeated ultrasound of the adrenal gland, and there was no suggestion.
How long is
and the PET scan didn't show anything in the adrenal glands. So since it was a secondary atrophy, so PET was normal in adrenal gland.
This patient responded to steroids and still on the steroids, I presume. What is the dosage which you are presently putting the patient on?
We have started with 30 milligram and over 3 weeks, then reducing dose every 3 weeks, 10 milligram, and I will keep him on 10 milligram steroid unless he gets back his symptoms, and then we'll follow him up in the clinic.
Thank you very much. I must congratulate you for presenting a very good case here. The highlighting point is that patient has it's a fever of unknown origin. At the same time, large vessel involvement. We think of Takayasu first. We think of Takayasu. But then there are other features to account for sarcoidosis, like hypopituitarism and calcium level is high. And how common is that large vessel involvement in sarcoid? This is number one. Number two is that often another cause of pyrexia of unknown origin with joint involvement and is brucellosis. Brucellosis is another that
we have ruled out brucellosis. We have done agglutination test, IgM, because that is only available in our state. And we don't have any culture media for brucella.
It also causes vasculitis, but it is usually cutaneous. Leukoplastic vasculitis, large vessel vasculitis is not caused by brucella. But I am very, it is surprising to know how the large vessel involvement in case in this case, presenting with sarcoidosis?
No, what PET has suggested that they could identify few enhanced lesion along the wall of the large vessels and medium vessels, could be vasculitis, could be. They haven't said that it's a evidence of vasculitis.
Thank you very much.
Had there been involvement of the pituitary, what will be the future outcome after initiating patient on steroid? Will be pan pituitarism, hypopituitarism will be persisting, or you are expecting some improvement with the therapy?
Good question. It's certainly till now, all his other enzymes on the lower side, but it hasn't gone to hypo, is a FSH LH in a male patient has got no value, but the other hormones can have an effect. And already the hormone question is whether we should give mineralocorticoid or not. Since there is no adrenal hypoplasia, so mineralocorticoid is very much indicated in case of primary adrenal insufficiency. When you have no increment of your adrenal hormone with ACTH, but there was some suggestion that there is increment.
Now, my question is that if steroid is the only treatment for sarcoidosis,
yeah.
Yes. So in that case, if it is proved to be a case of sarcoidosis, extra pulmonary, and we want to get the expected therapeutic response with steroid, does other symptoms of pan-hypopituitarism, if it is there at all in this case, all this will improve?
Yeah, we need to follow him up. Yeah. Then I don't know, because possibly this is my third isolated extrapulmonary sarcoid. Other two, one was thyroid, one was again pituitary, but he didn't have any bony lesions. Okay. So this is the three cases.
Thank you.
Thank you. Thank you, Ajada.
Thank you.
I am winding up the session.
From the organizing committee of Medicon International, I would like to thank all of you for being such a patient audience. I would like to thank the satellite centers who have been very patiently listening to us. And a big thanks to Sun Pharma for organizing such a wonderful, wonderful program. Thank you all. Thank you very much.